I will talk about AI in healthcare. And I would like to start by saying that AI is not something that will arrive in healthcare. AI is already here. According to a recent survey by the American Medical Association, more than 80% of the physicians are currently using AI in a professional context. But the point I want to make here today is that AI does not save lives on its own. Better decisions do. These can be clinical decisions, such as what diagnostic test to order or what treatment plan to choose. These can also be operational decisions, like how should we schedule the patients, or how many intensive care units beds do we need. But when it comes to these decisions, the problem is not simply how do we develop better AI models. The problem is more about how do we design a decision system in which AI can actually help people make better decisions. And I will talk about 3 traps today that can actually prevent us of using AI to make better decisions. The first is what I call the fluency trap. AI can sound very polished and confident, so we trust it so much and we don't do proper verification anymore. The second is the certainty trap. These complicated models can give us very precise looking predictions, so we forget that some uncertainty still remains. And the third is what I'm going to call the abundance trap. AI can always give us more recommendations, more information, more tips, but the people who are actually making the decision have limited attention to act upon these information. So one of the main areas that physicians are already using AI for is to summarize research and standards of care. This is not surprising because we all know that these large language models are remarkably good at processing a large amount of information and write very clear summaries. Indeed, let me ask you a question. How many of you have used ChatGPT or Gemini to help you do research? Many of us, right? Now, I want you to ask yourself how often or how much effort you actually put in to carefully verify the sources and the claims contained in these AI-generated reports. Yes, much? Often? Not often? The thing I want to make here is that I think there's, in general, a lack of verification of these AI-generated results. And this is not just happening in low-stakes settings. This is even showing up in rigorous and sophisticated medical research. So according to a recent audit led by colleagues at the Columbia Nursing School, they actually examined 2.5 million biomedical papers, and they find a sharp increase in fabricated citations. These are basically references that look real, but they do not correspond to any actual publication. Another study found that in 2025 alone, there are more than 147,000 fabricated references in scientific papers. Well, we all know that AI hallucinates. And unfortunately, hallucination is not something that is going to be just a transient problem. And the reason is because, or one of the reasons is because the large language models are trained and evaluated in a way that is actually rewarding guessing rather than admitting uncertainty. A simple analogy would be, imagine yourself sitting in a multiple choice exam, okay, and you actually don't know the answer to that question. If there's no penalty for guessing, then your best strategy is probably to guess, right? Because leaving it blank guarantees 0, while guessing at least gives you a chance. And during the training process of these large language models, they share exactly the same incentive. And my point here is not to say that we should avoid using AI to do research for us. My point here is to say that for these high-stake decisions, we really need to think carefully about how to design verification as part of our workflow. Now let me move from generative AI to predictive AI. In a recent work, we developed a predictive model for emergency department demand. This is important because if the demand is higher than what we have planned for, patients have to wait, clinicians are overloaded, and the quality of care suffer. On the other hand, if the demand is lower than what we have planned for, then we're overstaffing a system that is already short on staff and facing high costs. So the model we have achieved an error rate of 8.7%, which looks pretty good. But let me ask you a different question. Why is the model making an error? Well, if you still remember what you have learned from stats or business analytics, here are some natural explanations, right? The model may not be advanced enough. Maybe I haven't used the most sophisticated neural networks. Maybe I do not have enough observations. Maybe there's not enough feature in my model. I should just go out and collect more relevant information. But let me push you further. Suppose I give you all three above. Suppose I give you the most advanced model, a large amount of observations, and all the features you have wished for. Would you expect we are able to push the error rate all the way down to 0? Most likely not, right? Because there are just some events that are intrinsically hard to predict. Something like a car accident, a surge of infectious disease, or even a mass casualty event. These things are just very, very hard, even for the most advanced model to predict accurately. And in most healthcare settings, AI can help us reduce uncertainty, sometimes substantially, but it cannot eliminate uncertainty. And knowing that distinction is actually very crucial because we need to build proper safety buffer to help us hedge against the remaining uncertainty. I hope you still remember what we have learned from the core operations management course. There we learned this problem called the news vendor problem. Okay? The key takeaway from that problem is that if demand is uncertain, you do not just plan for the average, or you do not plan for just what the prediction model tells you. You need to carefully balance the cost of having too much versus the cost of having too little while taking that uncertainty into account. Lastly, let me move to the clinical side. Okay. The advancements of AI and the growing availability of data have allowed us to develop more and more predictive models. These models can catch problems early, support clinicians, and introduce intervention before the patient actually deteriorates. But this promise also comes with a challenge. If every prediction model generates some alarm, and if every alarm requires some clinician's attention, what would happen if there are too many of these alarms? Well, this is not just a hypothetical concern. Physicians nowadays already work in an environment with an enormous amount of alarms. One ICU study found 187 audible alarms per day per bed. Think about the number for a minute. It is not 187 alarms for the whole hospital. It's 187 alarms for a single bed in a single day. Another study found nearly 70 alarm floods per day in a 21-bed ICU. Now, this brings the third trap, the abundance trap. The model can give us more alerts, can give us more information, more advice. But the clinicians who must act upon these information has limited attention. Traditionally, we would evaluate the quality of these AI alerts by its statistical accuracy. But in a recent study, we tried to really look into how these alarms are actually affecting the decision quality over time. There, rather than treating these alarms as isolated predictions, we really want to model it as part of a dynamical decision system where the clinician's attention and trust could evolve over time. On one hand, an alert now can give me more information, and that can be helpful for me to deal with my current patients. On the other hand, the alarm also takes my valuable attention, and that might actually affect how I would interact with the system in the future. If there are too many of these alarms, and sometimes there are false alarms, then I might trust the system less, be less willing to respond to the alarm, or simply be less capable of differentiating which alarm deserves my true attention. So I would like to end with where we started. AI is already here. Physicians are using it. Hospitals are experimenting with it. But AI does not improve health by itself. Better decisions do. We talk about 3 traps today. The fluency trap. For us, we should always verify what AI says, especially for high-stake decisions. We talk about the certainty trap. We should always be aware of what the AI cannot predict and build a safety buffer to hedge against it. And lastly, which I also personally think most importantly, we should avoid the abundance trap. AI can always give us more information, more alarms, more recommendations, but humans have limited attention. So we need to be mindful to protect the attention of the people who have to act upon these information. Thank you.